here today. So over the course of the next 45 minutes, I'm going to be talking about small circuits for small babies, how we can provide kidney support to neonates and infants. These are my disclosures. I am a consultant for AKI Foundation and have previously consulted for CHF Solutions, and I will be discussing off-label uses of Aquadex and Prismaflex because none of them are FDA approved for the patient population that we are discussing today. I do not have any conflict of interest with this program. However, I'll be discussing our clinical experience here. So my objectives are to just give a brief overview of the epidemiology of neonates who require kidney support, discuss some of the features of devices that are available to provide this kidney support, and review the program here at Seattle Children's Hospital, our experience with aquapheresis, how we select patients, prescribing therapy for them, what are some of the challenges we have faced, and how I see the future with all the newer devices that might be coming into the market. Let's just start with a case here. So this is a 5-day-old baby born at 38 weeks gestation, had a complicated delivery. There was placental abruption, chorioamnionitis, perinatal asphyxia. The birth weight was 3.1 kilos, but the baby weighs 3.7 kilos today. And these are the labs you see on the screen. There's hyponatremia, hyperkalemia, acidosis, PUN and creatinine are both elevated. The baby has significant fluid overload and urine output is dwindling. And nephrology team is called for a consult. This is this is fairly typical of some of the consults we get in the NICU. And when you get called for this baby, some of the questions that come to mind are, should you or would you initiate some kind of kidney support therapy? Now that question itself is a fairly big, broad ethical discussion, and I'm not an expert on that. I would direct you to some of the writings by my colleague, Dr. Aaron Whiteman, to read about the ethics of neonatal kidney support. But we can discuss some of the practical issues. How will this child do on kidney support therapy? What mode, what machine should be used? What should our prescription be? And what issues should we watch for? How do we counsel the parents when we are trying to get informed consent from them? So let's start with epidemiology of kidney support. This table here summarizes some of the studies that have been done primarily in neonates who received various forms of kidney support therapy. If we focus on the important things here, so as you can see, patients received varying kinds of therapy, whether it was CVVH, CRRT, CVVH-DF, peritoneal dialysis, and the weight ranged anywhere from 500 grams all the way up to 7 kilos in this one study, which included infants as well. And the survival varies. It was as low as 15% in this particular study out of Korea, where the babies were also much smaller. Whereas this study here out of England, which had neonates and infants slightly bigger in size, they had better survival, especially in those who had end-stage kidney disease. So one thing this table shows us is that you can provide kidney support to very small babies, and the survival varies. It might depend on what their underlying etiology might be. It might depend on how big the baby is when we start dialysis. Some more studies here. Again, these studies, they included both neonates and infants, mostly weighing less than 10 kilos. And again, we see here the survival ranges anywhere from 32% to 57%. So still fairly low, but perhaps things are improving over time. If we look at long-term outcomes, various studies have shown that babies can be supported with dialysis and survival outcomes are getting better. The Kaplan-Meier graphs on this slide, these are figures from Dr. Sanderson's paper looking at the US RDS data on neonates who started peritoneal dialysis. If we see the black line here, That represents babies older than 1 month of age who started dialysis between 2000 and 2012. And their outcome is similar to the blue dotted line on top, which are neonates who started dialysis in the same time frame between 2000 and 2012. And the lower lines, the red and yellow lines here, they represent the older cohort who started dialysis for those corresponding ages between 1992 and 1999. So over time, outcomes are getting better. One could make an argument that this is registry data. So this probably just captures those patients who make it to their entry into a registry. But we can discuss that another time. Overall, I think we are starting to get better at providing therapies for these patients. We've also seen that babies can be supported with both peritoneal and hemodialysis in the long run. However, these babies are at risk and they require a lot of special collaboration and a huge team, a huge village to manage them. Now, we discussed some how they do. What are the options available for providing therapy for these patients? The three big options are hemodialysis, peritoneal dialysis, and CRRT. And how we choose any of them, a lot depends on what the patient has, how big is the patient, what is their underlying disease, are they hemodynamically stable or not? What are the goals of our therapy? What are we trying to achieve here? Do we want rapid toxin removal or metabolic control? Or is this patient going to require long-term therapy for end-stage kidney disease? And then what do we have available at the center where we might practice? When I was training in India, we used to put in peritoneal dialysis catheters on our own, and we would start PD there. And CRRT was reserved for very few cases, whereas at my current center, we don't have the strong surgical support that some other centers might have. And we end up doing more CRRT than acute peritoneal dialysis. So it's not to say one therapy is better than the other, but you might have access to some treatments and you might be better at doing certain therapies more than other forms of renal replacement therapy. If you look at what devices are available, some of you may be familiar with these devices. There is the manual peritoneal dialysis set, often used in neonates, whether it's in the cardiac ICU or the neonatal ICU. There's the PD cycler. Once the baby is getting slightly larger volume, larger fill volumes, or it's an infant who's probably on the floor, they might be able to transition to the cycler. These are some of the CRRT machines available, multifiltrate, next stage, Diapac, and then some more machines available here, Prismaflex, which might be one of the commonest machines used in for pediatric CRRT, Carpe Diem, which is the new kid on the block. NIDUS is a machine that's available only in the United Kingdom currently. And then there's Aquadex, which I heard from Dr. Rowe that you all started your program recently, so you might be familiar with that. Most of these devices are not pediatric specific, except for Carpe Diem and NIDUS. The advantage of having a pediatric specific device is that when it's made for babies, it can probably work with a lower blood flow. So you can get away with using smaller catheters. At the same time, when the devices are made for smaller kids, they also have a smaller extracorporeal volume. So one, they require lower blood, there's a lower need for a blood prime. And even when we do a blood prime, those blood primes are likely to be safer and a patient might be more stable when we do those primes. If we look at the, put all these machines together and look at their features. So like I said, NIDUS and Carpe Diem are the only two which are pediatric specific devices. Prismaflex is not pediatric specific, but it has small filters available. Same goes for multifiltrate, which is the Fresenius device. It has smaller filters available. Aquadex is, again, not pediatric specific, but it can be adapted. All except the NIDUS are available in the United States, and they can all be used to perform various kinds of continuous therapies, whether it is CVVH, CVVHD, or CVVHDF. Looking further into their filters, so again, you'll see the extracorporeal volume in this column here. It ranges from as low as 17 mLs for NIDUS, all the way up to 93 mLs for the M60 filter, which is available for use with Prismaflex. Aquadex has an extracorporeal volume of 33 mLs, and Carpe Diem ranges anywhere from 27 to 41 mLs. Of these, the ones that are available in the United States, 33 mLs is the smallest filter for babies. We have that available with Aquadex and Carpe Diem, and 93 would be the largest one in this in the pediatric specific or the smaller filters. Depending on the size of the filter, the blood flows also vary. So this is where what we talked about, that if you have a smaller filter, you can get away with smaller blood flows. So that's the advantage of a machine like Aquadex, where you can work with a blood flow of 10 to 40 mLs per minute, or Carpe Diem, which works at a blood flow of 2 to 50 mLs per minute. The bigger filters have wider ranges, 10 to 100 or 50 to 200 mLs per minute. And their accuracy or the tightness of fluid removal control also varies. For the most part, most devices are between about plus minus 10%, and Carpe Diem is the only one which has a much narrower range for accuracy of 1 gram per hour. So let's talk a little bit about Aquadex. You might have one of either of these machines. The blue one, which is what we use, is the older machine. And I believe the gray one, the SmartFlow, is the newest iteration available. So this machine was FDA approved for continuous ultrafiltration for either temporary or extended use. And it's approved for both adults and pediatric patients weighing more than 20 kilos. The typical use was for diuretic resistant fluid overload. Now, if you look at literature on Aquadex, lots of papers were published back in the 2010s on the use of Aquadex for patients with heart failure, comparing it with IV diuretics. And that was the initial intended population for this device. There were a couple of case reports of using Aquadex for ultrafiltration in smaller patients as well, but it somehow didn't really get a lot of traction in that market, and I think it wasn't used as commonly as they thought it would be. And I think I remember hearing from Dr. Rowe, that is kind of what happened at your center also. I believe the machines were available on the adult side and they were not being used the way it was meant to be. So this cartoon might be familiar to folks. There are always folks who are the innovators and early adopters. And I credit Dr. David Ashkenazi at the University of Alabama for being an early innovator in this field. What he did was he and his group at Birmingham, they decided to modify Aquadex to try and provide some clearance or continuous veno-venous hemofiltration. So this cartoon here shows the traditional use of the device. The blood came out of a patient who had fluid overload. It was heparinized, went into the machine where ultrafiltrate was generated, and the blood was returned to the patient. What Dr. Ashkenazi thought was, if we could increase the rate of ultrafiltration and provide some replacement fluid, you could get some clearance using convective mechanism. So here in their schematic, blood came out of the patient, got heparinized, you added some replacement fluid, ultrafiltrate was generated, and the blood went back into the patient somewhat cleaner with less toxins, with less BUN and creatinine in it. And thus they were able to provide therapy for smaller patients using Aquadex. So like I said, this is what the machine was approved for by the FDA. If we look at what we use it for at our center, it's mostly off-label. About 2/3 of our patients get modified CVVH or continuous veno-venous hemofiltration. Another 1/4 patients get prolonged intermittent renal replacement therapy, and a very small number of patients get a SCUF with this. Since we started using this device, this is how our usage has been. It varies from year to year, but the yellow bars on this slide show the number of patients with the numbers on top of them. The pink line is the number of days on therapy, and the blue line are the number of circuits used. So our usage has varied anywhere from 4 to 5 patients a year, all the way up to 12 or 13 patients, and the number of circuits and days of therapy increase accordingly. We published our experience with Carpe Diem along with Cincinnati Children's and the University of Alabama, along with UAB. And this visual abstract by Dr. Joel Toff shows kind of a quick overview of our study. So we had 119 children total in our paper, and we divided them into 3 groups: the less than 10 kilo category, 10 to 20 kilos, and more than 20 kilo patients. In those patients who weighed less than 10 kilos, most of them underwent therapy for either volume overload or acute kidney injury, and CVVH was the most common modality for these patients. The hospital survival here was about 60%. For the older patients who weighed more than 20 kilos, most of them underwent therapy for volume overload, and they underwent just ultrafiltration only, and their outcomes were a 97% hospital survival. Overall, the therapy was fairly safe, with some complications seen in about 15% of the circuits, and 3% patients circuits had cardiovascular complications at onset. And I'll discuss the complications in the next few slides. So if we look at slightly more details of who undergoes therapy, in this less than 10 kilo age weight category, patients were about 19 days old, median age. The median weight was 3.2 kilos. And their underlying disease was either cardiac or a kidney problem for most of them. And some patients had other conditions as well. The indication for renal replacement therapy was variable. 45% patients had fluid overload as their primary indication. 40% had acute kidney injury, and a small group had end-stage kidney disease. Like I said, in this category, the less than 10 kilos, most patients, 2/3 of them underwent CVVH, and 20% of them underwent prolonged intermittent renal replacement therapy. And only a small group had pure fluid removal or ultrafiltration performed for them. And patients stayed, the median days on therapy was 9 days, but you see the interquartile range here, it went anywhere from 3 days to 33 days of therapy. So again, more details of who is undergoing therapy here. The patients who get modified CVVH are mostly neonates who have advanced kidney disease, who have end-stage kidney disease, and who are excuse me, either waiting for a PD catheter placement, or they have had a PD catheter placed and they are waiting for things to heal and waiting to initiate peritoneal dialysis. The other group, which undergoes modified CVVH, are neonates who have acute kidney injury and fluid overload. The folks who undergo prolonged intermittent renal replacement therapy, these were patients with acute kidney disease who had just come off CRRT. They were not stable enough for hemodialysis, yet they still needed kind of maybe 6 to 12 hours of therapy, or they needed breaks for occupational therapy or physical therapy. So then they would only get nightly renal replacement therapy with Aquadex for 8 to 12 hours overnight. And then scuff was mostly performed in the cardiac ICU patients who had fluid overload without significant acute kidney injury. Moving on to the details of how we set up the machine and set up the circuit here. So this is how we had originally set up the circuit. You had blood coming out of the patient. Heparin was given before the filter, so pre-filter, and we gave our replacement post-filter. And I'll come to the reasons why we made that change. So this, as you'll see, is different from what Dr. Ashkenazi had published. The schematic for scuff was the usual. You had heparin being given pre-filter and blood going back into the patient. So this is where you see the difference. So in Dr. Ashkenazi's paper, they had replacement being given pre-filter, whereas we had replacement being given post-filter here just before the blood was returned to the patient. Over time, our circuit has changed. This was our original circuit where we had heparin pre-filter and replacement post-filter. But in 2018, we started having some issues with the heparin being given pre-filter. So we switched that also to be given post-filter. And since heparin is systemically anticoagulating the patient, it does not necessarily matter if you're giving it pre or post, or you could also give it to the patient via a separate line. It would not change much here. The axis that we use is typically a 6-French double lumen power pick, which can be cut to size, cut to length. We can also use 2 single lumen catheters. We've had a couple of patients who've used single lumen catheters, and these catheters are usually a 1 3-French catheter and a 4-French catheter. Ideally, they should be power rated or a power pick, so the catheter doesn't collapse when you're putting negative pressure on it for blood flow into the device. The usual prescription that we write for the blood flow ranges from 20 to 40 mLs per minute. The device has an ultrafiltration rate going up to 500 mLs per hour. Anticoagulation is typically heparin. We had planned for citrate when we had started using this for regional citrate anticoagulation, but we soon realized that was going to be very complicated. So we decided to stay only with heparin. We use Foxilum as our replacement fluid, and this is standard for all patients who receive CRRT at our center. We used to use Prismasol, but a few years back we moved to Foxilum. And the dialysis dose can be either 30 to 35 mLs per hour or 2 liters per 1.73 meters square per hour. I just want to talk quickly about the CRRT dose or the dialysis dose here. Now, the usual dose that we think of, the 2000 mLs per 1.73 meters square per hour, that is extrapolated from 30 to 35 mLs per kilo per hour for a 70 kilo adult. Now, if you look at this graph here, so let me walk you through this graph. So here on the x-axis, you have the weight of the patient or the body surface area of the patient. On the y-axis here, sorry about the typo here, on the y-axis you have the dialysis dose in mLs per hour. And this y-axis shows you the relative proportion of the mLs per hour versus the mLs per, the 2000 liters, 2000 mLs per 1.73 meters square versus 35 mLs per kilo per hour. So if you look at these older patients, the larger patients whose weights are closer to adult size, the ratio is about 1, which means the number that you get using either of these formula are about the same. Whereas if you look at the smaller patients, particularly those weighing less than 7 kilos, If you do the 2000 mLs per 1.73 meters square per hour, that can be almost 3 times as high as the dose that you would get with 35 mLs per kilo per hour. So that's something I usually like to prescribe in terms of mLs per kilo per hour using the 30 to 35, but there are no big studies that have been done on CRRT dose. There are no studies at all that have been done in pediatric CRRT dosing. So I'm not sure which one is right or wrong here. And the important thing is to, I think, have a protocol and follow that protocol. Next, we come to blood primes or circuit primes in general, and when should we consider doing a blood prime? We usually use, if your ratio of extracorporeal volume to total blood volume is more than 10 to 15%, then one should consider using a blood prime instead of a saline prime, particularly if the patient is already hemodynamically unstable or has a low hematocrit. They might do better starting the circuit with a blood prime. Now, this table here shows you the various circuits that I said, or sizes that are said are available, ranging from 33 mLs to 93 mLs. And you'll see that even with the smallest filters, many babies end up requiring blood prime. Now, if you look at the ratio, let's say for a 4 kilo baby, the ratio of extracorporeal volume to total blood volume, that can be 10% with the Carpe Diem small filter or with Aquadex, and it can be as high as 29% with an M60 filter. So here with the M60 filter, for example, 1/3 of the patient's blood volume could potentially be outside their body in the circuit, and even if you're using a blood prime, banked blood has very low pH. It has high potassium, lots of citrate, has low calcium. So when this 30% of that acidotic, hyperkalemic blood mixes with the patient's blood, the patient is likely to have some kind of hemodynamic instability at initiation. So the lower your ECV to total blood volume ratio, the more safer your blood prime is going to be for the patient. And at our center, we have created these tables to make it easy for everyone, our trainees, to kind of think about when should we use a blood prime and when should we use a saline prime. Coming on to the complications seen during therapy, like I said, this is data from our paper again. For the most part, the therapy was very safe. We saw complications at onset in about 3.3% of the circuits, and this included patients having hemodynamic instability. They required either a saline or an albumin bolus, or they required an increase in the inotrope dose that they were already on. Other complications seen during therapy were also fairly infrequent, seen in about 15%. And most common was bleeding from the catheter site or hypotension during therapy, or typically catheter-related issues like a malfunction or a clot in the catheter. Now, what are some of the challenges that we have seen during therapy? So we've had some issues with accuracy of the fluid balance. As you have seen now, that the device was meant for ultrafiltration. So it does not have a pump to provide replacement fluid, which means that your replacement fluid pump is external to the device and they don't communicate with each other. So that can cause some imbalance. We've also had some issues with air alarms when we were giving pre-filter fluids, and then hypothermia. So let's look into some of these things in more detail. What we started noticing after the first few patients was that with some patients, their fluid balance did not quite match the clinical appearance. So what I mean by that is that on paper, it looked like they were 200 ml or 300 ml positive for the day. But when you looked at the baby looked dry or had hypotension, and things didn't quite make sense. And we had this issue more when we were using a higher clearance, or if the line was not working so well. So our nurses, wonderful nurses, they set on this mission to figure out what was going on. And we did this exercise for about a week, where they would document what the machine was recording when it said that the effluent bag was full. So for example, if we follow this first row here, the machine recorded that 960 ml of ultrafiltrate was removed. And when they weighed the actual bag, when they weighed the effluent bag that they emptied, that had a 1009 ml of fluid. So there was 49 ml fluid, which was removed from the patient, which was not accounted for by the machine. And this pattern continued at various points. It ranged anywhere from 30 ml to 50 ml. And over a 24-hour period, this could add up to something like 200 ml all the way up to 320 mLs. And all of this was within the margin of error of the machine. Like I showed you earlier, the margin of error for the pump is plus minus 10%. And most of this was ranging in the 3 to 5%. Most of this was in the 3 to 5% range. But it obviously, for a 70 kilo patient, the 300 mLs over 24 hours might not mean a whole lot. But for a 4 kilo baby, that's a significant volume that can change their hemodynamic status. So like I said, we noticed that this was the issue with the ultrafiltration pump, and this was within what the manufacturers had said it would be. And it was a higher issue. It was a greater issue if we were using a larger clearance, larger ultrafiltration, especially when we went above 300 mLs an hour. So our current practice is that the nurses weigh the effluent when they empty the bag, and they document that volume or they document the discrepancy that they see. However, despite doing this, we continue to have issues with some patients. And again, this does not happen always, but there's usually the one patient who everyone remembers where things don't go right. So this issue continued. And as you know, fluid balance is intake minus output. And here, because of the wonderful nursing team, we knew that our output was reliable, which meant there was probably an issue with the intake. That was hard for anyone to accept, that how could there be a problem with the intake? Intake was the replacement fluid. And this might be familiar to many of you. This is what some of the ICU patients look like. They might have 5, 6, 7 of these infusion pumps, whether we use Alaris at our center. So whether it's Alaris or Brown, each patient is on multiple of these, is getting fluids through multiple of these pumps. So nobody was willing to accept that there could be something wrong with any of the pumps. So we did some more digging here, and we found that even for Alaris, which is a peristaltic infusion pump, the manufacturer says that that has an error margin of plus minus 5%. And neonates and infants typically don't get IV fluids at 200 or 300 mLs per hour, which is what we use for CRRT when we are connecting them. So people don't realize that plus minus 5% error. It's usually smaller and it does not make much of a difference. But and most of the times they might have a better access. They might be getting much lower rates. But when we are doing CVVH with these high replacement rates, and if we have a poorly functioning catheter, that's when this problem gets exaggerated. This is from the monograph of the device, where they say that the rate accuracy is plus minus 5% in general. But if there are high back pressures, the infusion can be slowed or decreased by up to 9%. And on the other hand, if you have low back pressures, if you have a really big line, the infusion rates can be increased by up to 7%. So again, this might not matter so much for a larger sized patient who's getting fluids at 50 or 100 mLs per hour, but it does make a lot of difference clinically for a neonate who's getting fluids at 300 mLs an hour. We don't have a great solution for this right now. We tried weighing the replacement bag, and that did not work so well because the replacement bags are not changed as often as the effluent bags were. So right now we just weigh the effluent and we make sure that the output is accurate. We usually assume that the intake or replacement from the pump is likely an underestimate, and we kind of try to keep that in mind when we are planning the fluid goal for the patient. So trying to base that on the overall appearance and not just the numbers that we see in EPIC. Other challenges that we saw were these air alarms with the fluid. So Aqueducts does not have an air trap in it. It has an ultrasonic air detector, which is located here in the pre-filter part of the circuit. What we saw was when we were using pre-filter heparin, we were having lots of negative pressure alarms in the system, and it was causing some entrapment of air. And it's hard to say, it was probably the first few patients or some patients where they either had a bad catheter or the line was not functioning so well. But this issue improved once we changed our heparin to be post-filter. This was the same reason why we started out with using replacement fluid post-filter. We had similar issues, and that we saw in our very first patient. So right from the beginning, we had to use post-filter replacement fluid. Now, if we go back to this slide again, as you see, the air detector is in the pre-filter part of the circuit, and there's nothing in the post-filter segment. So when we are giving post-filter fluids, it bypasses the air detector, and one needs to be a bit more cautious with that use. So far, it's worked well for us, and we have not had any issues with giving fluids this way. Some of the other centers have reported that sometimes they see micro bubbles in the replacement bag, which causes air alarms. I put those images there of Mountain Dew and the champagne glass because they say that it looks like Mountain Dew or champagne with those tiny bubbles in there. We have not seen this here, so I'm not quite sure if it's because we use Foxilum and the centers which have reported this use Prismasol. So it could be related to maybe the Prismasol fluid itself, or it could be related to the fluid being warmed if you're using a fluid warmer. And Daryl Ingram, one of the nurses at UAB, his recommendation was that just to, intermittently thump or tap the back to get rid of the bubbles, and that seems to work for them. And the final issue is hypothermia, which I think is universal to all patients, all pediatric patients receiving CRRT. At most centers where replacement is given pre-filter, they warm the replacement fluid using whatever warmer they might be using at their respective centers. Those are the two common ones that we reported in our paper. At our center, we warm the baby with a warming blanket and other mechanisms. And the reason being, like I said, we use our replacement fluid post-filter. And when you're using a fluid warmer, sometimes that can increase the risk of air bubbles in the fluid. And because we are bypassing the air detector, we did not want to use a warmer in the fluid for the fluid. So how do we choose therapy for a patient? It all depends on, you have to weigh the risks and benefits, look at the balance. And when I Googled balance, these are the kind of images you see. For some reason, people like creating these things with pebbles on the beach, I guess. So it's all about balance here. And this is what we had come up, the schematic we had come up for our center. If you had a neonate or infant who required kidney support, if they needed ultrafiltration only, they would get Aqueducts. If they required clearance plus ultrafiltration, and they were getting either some kind of tandem therapy, whether they were getting ECMO or plasmapheresis, or somebody who required very high rates of clearance for, say, hyperammonemia, they would get Prismaflex with HF20. If it was a small baby less than 4 kilos who required a standard clearance, or a baby in that 4 to 8 kilo weight category who could only get a 6 French line, they would get Aquadex. Now, this was before we got Carpe Diem, and the new machine was available in the market. So Carpe Diem, just very briefly, is the newest pediatric specific, or is one of the pediatric specific CRRT machines. It's the only one that's available in the United States. It recently got FDA approved for this 2.5 to 10 kilo weight category. And the advantage is all the things that I'd mentioned earlier. It's a pediatric specific device. They have miniaturized peristaltic pumps, so it's more accurate. You can work with a blood flow as low as 2 mLs per minute, going up to 50 mLs per minute. And it's highly accurate. The weight loss accuracy is plus minus 30 grams in a 24-hour period. And this is as compared to the plus minus 10% that we saw for all the other machines. The filters can be used for a maximum of 24 hours, and the 2 filters available in the United States have extracorporeal volumes of 32 mLs and 41 mLs. And our current schema is probably looks something like this. So if you have a patient who weighs less than 10 kilos, if they require ultrafiltration only, they will get Aquadex. If they require clearance, then we kind of look at, are they undergoing ECMO? Are they getting plasmapheresis? Does this patient get large volume infusions or transfusions, hyperammonemia, acute liver failure? Some of these, if they have any of these factors, then they're probably better suited for Prismaflex. If they don't have any of these factors, then they can be considered for Carpe Diem. And if Carpe Diem is not available, or if it's in use, the same patients would get Aquadex. Somebody who weighs more than 10 kilos, perhaps a little bit simpler there. If they require only ultrafiltration, they can get Aquadex. If they require clearance, they can get Prismaflex. Some of you might remember this meme from last week. This was very popular. I think of this as Aquadex, Prismaflex, Carpe Diem, and peritoneal dialysis. And I thought it was pretty apt for that, for the devices that we have. So coming back to our case, like I said, this was a 5-day-old baby who had 20% fluid overload, was not making so much urine. So after discussing goals of care with the family, with the neonatal ICU team, everyone decided that kidney support was the way to go about it. And either of these 3 options would be good for this child, whether it's doing acute peritoneal dialysis. There are certain risks or issues associated with that, which I didn't cover today, but that can definitely be done. Or you could do CRRT with Aquadex and a 6 French line, or CRRT with Carpe Diem and a 6 French line, depending on what is available to you. So just to summarize for Carpe Diem, for Aquadex, it's a useful part of our toolkit. We have smaller circuit, can be used with smaller catheters. Patients can start therapy without significant cardiovascular decompensation, and it's a good bridge to peritoneal dialysis for those who require long-term therapy. Overall, therapy is pretty safe. However, because the replacement fluid and ultrafiltration are through 2 separate pumps during CVVH, it does require close monitoring by either the CRRT nurse or the NICU nurse who is performing the therapy. And it also requires a holistic evaluation of their fluid balance, not just looking at the numbers. And overall summary would be that kidney support can be provided to very small critically ill patients. How we provide it, what modality we use, depends on various factors. And overall survival varies. There is definitely some bias in the centers which perform therapy. And even at our center, when we started performing the therapy, we started doing it for patients who 5 years back might not have received any kind of renal replacement therapy. So definitely the mortality was higher in the beginning. And multiple challenges exist, but I'm happy that we are moving away from adapted devices to pediatric specific devices, and we no longer have to use we're no longer restricted to just bigger machines like Prismaflex or Multifiltrate for providing CRRT for these small babies. This is some of my nursing team who provide CRRT, and this is the only photograph we have. We took this picture last month when we did our training for Carpe Diem. Larissa Yalon is our CRRT nurse manager, and the ACE nurse team, which the advanced CRRT and ECMO nurse, who without whom I don't think we would be able to provide any of these therapies. And then I put Dr. Goldstein, Dr. Askenazi, Jolyn, and Teresa. They are what I call my CRRT think tank. Anytime I have issues or questions, they're always happy to answer and troubleshoot things for me. With that, I can take questions now. Thank you so much.
Thank you so much, Dr. Menon. That was a great overview of aquapheresis and renal replacement therapies in infants. And if anybody has any questions, please put them in the chat. We have a couple minutes to go over those. So we have one question in the chat. What is the advantages of Aquadex over scuff? And I think what they mean is Aquadex plus replacement fluid versus scuff alone.
Yeah, so if you have a patient who has only fluid overload, which is something you might see in we often see it in the cardiac ICU, they might not require clearance. So their BUN, creatinine, potassium, or bicarb, those numbers are fairly well balanced and you don't need to manage those. In that situation, you can just do scuff and remove the fluid. But if they also have a significant AKI and require adjustment of or management of their electrolytes, then I think doing CVVH would be better for them.
And then kind of a similar question to that, that I have, people describe the disadvantages of aquapheresis is that it doesn't have the dialysis piece. So it doesn't have that countercurrent dialysis fluid that's running at the same time. Have you run into situations over the past few years where that's been a problem, where you haven't been able to get the clearance you need just with the aquapheresis and the replacement fluid alone?
No, actually not. That's a very good question. But we have not had that issue because overall, I think when you look at convective clearance, which is what Aquadex provides, versus dialytic clearance, I would say probably convective clearance is slightly better. You get the slightly larger molecules, the middle molecules can be removed through that, whereas dialysis would only target the smaller molecules. And so convective would target both the small and the larger molecules. So you would end up getting slightly better clearance. Studies which have looked at CVVH versus CVVHD versus the combination, I don't think they really showed much difference in outcomes with either of the therapies. The only situation where we found Aquadex was not very helpful or would not be very helpful is somebody who requires renal replacement for hyperammonemia. So, and I didn't show that slide here, but as you know, like for hyperammonemia, we are trying to provide the same clearance as a hemodialysis session with CRRT, and our clearance can go as high as 8,000 mLs per 1.73 meters square per hour. So 4 times the normal clearance that we would provide. And for a 4-kilo baby, if you do the calculations, that comes up to be something like 1 liter per hour of replacement fluid, which is beyond the ability of Aquadex. So that would be the only situation where I would not use Aquadex for CVVH, but otherwise for most other patients, we are able to provide similar kind of clearance.
Great. So we have a question in the chat that came to us from Dr. Nahara, one of our nephrologists. When using heparin for Aquadex, what parameters are you following? The ACT, 10A levels? And then are you using different heparin goals for small infants versus the older kids on CRRT?
We use the same we use PTT, and we use 40 to 60 seconds for our goals. So it's not a very high goal there. And the reason why we have stayed with PTT is because our lab said that at that level, the anti-10A would be probably undetectable or just in the 0.1 or so range. So we wouldn't be able to make adjustments based on anti-10A levels. So that's why we have stayed with PTT so far. And you don't change our thresholds. We use the same for all our patients.
And then we have one question for me that I can answer quickly is Dr. Stucker is asking which, if any of these, we may start to see at Masonic Children's Hospital. And we currently have the Aquadex available. The nurses are only trained in the pediatric ICU and in the CVICU. So if a NICU patient would need dialysis or need one of these therapies, we would need to transfer them over. If we find that we need or that we're using it frequently, then the next step would be training the NICU nurses to provide this therapy. But I think as Dr. Menon showed, this is relatively rare to need, maybe 12 to 20 patients a year, maybe less. So it's hard to keep nurses trained to do these kind of therapies. And then we have a question from Dr. Balani, who's also one of our nephrologists, and asking about your experience using Carpe Diem. And do you think that Aquadex is going to be used less? Is that going to kind of fall off the side now that we have Carpe Diem?
I don't know. It's hard to say. It might fall off over the next few years or so because Carpe Diem is so new, and I think probably 5 centers in the country might have it right now, and folks are just now starting to get it. So the places where, right now, I think with COVID, like a lot of budgets were cut short. So many places were not even able to buy it. Like those who want to buy it might not be able to buy it. So I think until then, Aquadex definitely has a role to play. And once all centers have Carpe Diem, probably, at least this version of Aquadex will not be in much use for CRRT, for CVVH. It might still be used for just scuff.
Mm-hmm.
For scuff, I see the advantage between, say, Aquadex and Carpe Diem, that Aquadex the filter will last for more than 24 hours. So you can provide it for 3 days, whereas there you have to change the filter every 24 hours. So that would be one advantage for scuff.
And then a technical question from Dr. Balani also, can you use citrate with Carpe Diem, or is that heparin-based as well?
You can citrate with Carpe Diem, and we have had 2 patients so far. We did one actually we did without anticoagulation. Patient had some coagulopathy, but the second one we used citrate. It's a learning curve for us because when using citrate, it's always like you need extra lines for measuring levels and getting ICALs. It's a little bit easier if you're doing heparin, but our patient had bleeding issues, so citrate was a better option there.
All right, and then the last quick question. I think when we have these new neonatal therapies, everyone's always interested in what's the smallest size that you can dialyze with these new machines. And my guess is that it's limited by being able to get the catheters in. But what's your experience in Seattle and kind of the lower limits?
I think in our paper, we reported a 1.4 kilo baby as being the smallest. And you're right, it is limited by the catheter access. So for those smaller ones, the 6 French might be difficult, and 2 single lumen catheters might be the way to go.
Well, thank you so much for sharing your expertise, and I'm sure I will reach out as we get more experience with this to help you troubleshoot.
Sure,
help us troubleshoot.
I'd be happy to answer questions. Thank you for inviting me.
All right.
Thank you all. Have a wonderful day, everyone.
Bye.